Mahipal is having the first shot. My journey with ELITA, please.
ठीक है, it'll be a bit. Yes, ma'am. Optimal better than Lapiada, but Lapiada probably.
Well, good afternoon again, and I'll be talking about my journey with ELITA. I think I was fortunate enough to be associated with the development of the ELITA right from the beginning. And I think 2018, and then during COVID struck, and it was a real difficult time, but I think we worked through it, and we brought the platform ELITA to fruition. When you look at the lenticule extraction, or I would rather say the refractive laser vision correction platforms, so there are been the thought process of working on the cornea to be able to actually get rid of refractive errors, and this thought was published first by Lan in the refractive surgery way back in 1896. Sato performed RK from inside the cornea, and obviously that had a lot of corneal edema and things like that. And then you have Barakar. He was actually the first person who came out with the idea of keratomileusis, that means to reshape the cornea from within. And I think there was the ALK that was launched subsequently. Theo Seiler was the person who did the first PTK, wherein the excimer laser was used, and then you have Margaret MacDonald working on non-sighted eyes, and then Palikaris. He was the first person to actually make a flap in the cornea to get what is known as LASIK. And then there have been further additions, etc. And Sikendo and Dr. Rupal Shah then subsequently in India performed the first smile procedures which were there. So that was the onset of the lenticule extraction. And when you look at this, we have the SMILE procedure, which was born in 2007, and that was, I still vividly remember, it was in the American Academy of Ophthalmology, where it was said that maybe by just taking out a lenticule without an excimer, you could get refractive corrections. Was really something that I was surprised that, well, this can happen. But then things have developed along, and the ELITA machine, all safe. Then the ELITA machine, basically in 2018, that is when the first laser was fired for the first time on the ELITA. That was on the clinical, and obviously we started with the flap, and this is the first flap that is being done in the year 2018. And thereon, once the flap was perfected, the proof of concept of the laser working was there, that we looked at performing the first silk procedure on 4th of January 2020. And so some people ask that it's a new procedure when patients come. So I said, well, we have an experience of more than 5 years now, and I'll be just talking about a couple of results. So this was the first procedure that was performed in 2020. Now, in 2023, because there are now 4 or 5 companies that have the lenticular extraction, the nomenclature today from the individual names, like you have Silk or Smile or you have Clear, etc., has been changed to what is known as Kalex. So Kalex is the name that is there, and that stands for keratorefractive lenticule extraction. That means any type of machine that you are taking working on, and if you are removing a lenticule to get refractive correction, that is called as Kalex. Now, when we started the ELITA, it was called as Cheetah, and that was the study name, cheetah being the fastest animal on earth. So this was the fastest laser that was there, that was developed. So the project was called Cheetah, and then subsequently it is called as ELITA, and the lenticule procedure, as one would say, smooth as silk. So that is the silk procedure which is there. Now, when you're looking at the ELITA procedure, it's basically designed for a flapless refractive correction for lenticule removal. As of now, it is available for myopia and astigmatism, which is there. The biggest advantage of this laser is that it delivers extremely low energy treatment, which is there. And the pulses are ultra short pulses, ultra fast pulse frequency, and it has a very small spot size. What this does is that it creates fast and smooth cuts. The biggest other advantage that is there is that the lenticule is a biconvex lenticule. There is no other lenticule that is a biconvex lenticule, and there is minimal tissue disruption in the stroma which is there. Now, when you compared the ELITA with the IFS, that was their interlace, you could see that the femtosecond or the time duration that is there is extremely brief, and that is 100 to 200 femtoseconds as compared to the interlace, which was 600 to 800. The pulse frequency obviously has to be much faster. The spot size is much smaller. It is smaller than all competitors, and it is only about 1.3 microns. So the typical example is if you have small spots, you can cut finer, and therefore the outcomes are likely to translate to better outcomes. The wavelength obviously being the same, but importance here is you have the pulse duration being very short, and therefore spot size also being less, and therefore the quantum of energy that is released on the cornea is very low. Obviously, if you are having low quantum of energy going into the cornea, the outcomes of the clarity of the cornea and the quickness of the visual recovery is going to be more. If you just compare the Visumax, the IFS and the ELITA, you can see this comes as a sharp energy but comes for a very short time. Now, the important thing here is that there is no line and there is no spot separation, which I think may be the future that we could have it, but there is zero spot separation, and what it means is that the dissection that you can do is very easy. You don't really have to struggle, and the incidence of retained lenticule extractor is extremely low. This is just a small little thought process or an experiment that was done, that if you have to rip a paper apart, and if you have thick spots with separation and you have 1 micron spots or lower spots, you can see the ease with which the separation, or you are tearing the paper. So that's something which is easy that you can get, and that is the basic concept. Have small spots with no spot or line separation and make it work fast so that you are able to get good dissection. Now, this next generation lenticular procedure, which is a biconvex lenticule, the indications are up to a maximum of -12, and that is the add of the sphere and the cylinder, but individually you can go up to -12. So if there is no cylinder, you can go up to -12 sphere, or you can go up to a -6 cyl that is there, but the sum of the sphere and the cylinder as is available today is 12. The total treatment time for an optic zone about 6.2 would be about 16 seconds of laser time, and as you all know, when you're doing a lenticular extraction as compared to an excimer, there is no difference in the time whether I am treating a 1 diopter or I am treating a 10 diopters, because it's just the depth that is going to vary, and it's not in an excimer. The time taken is going to be proportional to the refractive error that you are correcting. Now, just as a look, as you can see from the multiple platforms that are available, Visumax 500, 800, Zemer, and AIOS, and the ELITA, Johnson & Johnson ELITA system, wavelength being approximately the same. But what is very important in all these is that this is the repetition rate, and you can see this is the fastest laser which is there. The quantum of the energy, as told to you earlier, is about the least. The laser cut time is significantly less. The only machine which can outrun it today, because it has larger spot size, is the Visumax 800. The patient interface is flat in Zemer as also in ELITA. Cyclotorsion compensation and centration system, these were two fallacies in the earlier lenticular system which was there. Here you have them. Soon they will be automated. But as of now, you have to mark, but right from the beginning, the importance of having a centration, being able to change the centration after docking and to do a cyclotorsion compensation is there. Lenticular geometry, you have the lenticular side cut which is there. This is the docking. Those who have done the interlace can see that this is the docking, and you can mark the center of the cornea, and you can mark the, like you mark for a toric IOL, you can mark the axis for the cyclotorsion compensation. You press on the foot switch, get a vacuum. As the vacuum comes, you can see that you are going into the green area. As you go into the green area, you press, you pinch, and you get a full applanation. And we prefer to keep it in the upper half of the green part so that there isn't too much of compression. And this is the picture that you get, which is the cyclotorsion compensation that you can see, a 3-degree cyclotorsion compensation. There is centration which is there, and then you press on the foot switch. So this is for those who haven't seen the procedure. So this was, I think, 16.1 seconds or something. This is the posterior part of the lenticule, that means the undersurface of the lenticule. Then you had the round cut. This is the top surface, and this is the entry cut which you have. I normally prefer to keep a 3 millimeters entry cut. You can go down up to 2. This is how the picture looks, and it gets released automatically. Now, this is the patient interface which is there. This ensures easy docking and proper suction. The difference between this and the interlace is that there is no syringe-induced suction. The suction is actually going through the machine, and you can see that it is maintained at a steady state which you have. There is a flat applanation cord. Now, you could actually center the lenticule. You can mark it. You ask the patient to look into a microscope light. The microscope doesn't come as part of the machine. You can center it, and if you want to do a centration, you can easily work on it. Now, this is what you get at the end of the procedure. The only thing here is that because it's a biconvex lenticule, you have to go a little up, and then you go to the posterior plane. Once you have, I normally use a blunt dissector because the ease of dissection is very great. You don't need to have anything sharp. I really always use a blunt dissector, and you can see that this works pretty well. As you go on to the upper surface, then you go on to the lower surface, as you can see. Normally, it doesn't really, some people have a hesitation, if I go into the wrong plane, what is going to be the problem? It's not difficult at all. Even if you've gone to the wrong plane, you can ascertain the other plane very easily subsequently. And you can see the ease with which we were able to actually do a dissection or the separation. And majority of the people can put it as no dissection. Initial people who are doing should spread the lenticule to see that the lenticule is complete. By far, the incidence of incomplete lenticule is very little, and that's pretty much the end of the surgery. Now, the patient selection for the initial cases, as we looked at, the target patients were -6 and up to -2. That was the correction that we were having. Initially, we looked at patients who were amblyopic. That means that they didn't have good vision, and we worked on them. These are the normal patient selection criteria. So the first phase that we did was on non-sighted or partially sighted eyes or amblyopic eyes, and then we went on to work with the rest. And then I think, welcome Dr. Rohit, he's joined. Then Dr. Rohit Shetty was the second site where we had, and then there were 2 more sites, and that is where we looked at. So this study design actually has the combination of data from our center as also from NN, and these were the 2 sites, both in India. Again, it's proud moment for Indians, for us to be actually being at the cutting edge of technology and doing these trials. Open label, bilateral lenticle removal. It was a single arm. These were the normal criteria that you had. 170 treated eyes. We looked at the mean pre-op and post-op MRSC, uncorrected visual acuity, and the best corrected visual acuity. Now, when you're looking at these 170, right from the beginning, you could see that the results were very much bang on. We had tight results which were there. Uncorrected visual acuity, 20/20 or better as the time elapsed. Initially, if the vision wasn't like at 20/20, it used to tend to get better. There was no case in which we lost the best corrected vision in these cases. And within plus minus 0.5 of emetropia was in 94% of the cases. Now, what we found was that there was a slight undercorrection when we were looking at, specifically for higher powers. This is the scattergram that you are looking at. So there has been a nomogram adjustment which has happened, in which there is a slight increase in the power that we do, that is the minus 0.25 plus a small percentage of the refractive correction that you have, both for the sphere and the cylinder. And you can see the tightness of the results, that this scattergram, you had more patients coming here. You can see that they are within the standard deviation that we are getting. Now, important thing that we noticed right from the beginning was the ease and smoothness of the lenticle removal, and 91% of the cases required little or no dissection. So that is what you saw in the video, that there was hardly any cold spots or areas where you had a problem. This is how we, after every eye that we did, we were supposed to say as to whether the dissection was no dissection, mild dissection, moderate dissection. And this is the figures that you have, that mild dissection was required in 86% of the cases. This is what we got. And the clear corneas were seen at day 1. Vision recovery was really good. This paper has been published in the Clinical Ophthalmology. This is the full text that has been published. So far, I think it has had over 1,500 reads which are there. And this is what I would wish to say is our half-decade outcomes. We have crossed 5 years now, since January of 2020, and 60 eyes of 30 patients, pre-op minus 4.19, post-op is, you can see, 0.2. Contrast sensitivity is fantastic. As you look at the half a decade, the contrast is fantastic. No incidents or nothing much as regards the dry eye. The Shermer's was pretty good. And within half a diopter of emetropia, 90% of the eyes, and 1 diopter of emetropia, 95% of the eyes. So these are our personal outcomes. So this is something that I'll wish to say, that this is subject 1, that the first lenticle that was removed, and this is April Fool's Day, 1 day before Trump announced his tariffs. So, so this is what we have. What have we done is that the energy we have reduced significantly. So there are 3 things that we have done. One is that we always wet the cornea or slightly lubricate the cornea before we applanate. The second thing that we have is that we have reduced the energy. So the posterior energy, which was 60 nanojoules, is what I am using today is 34 nanojoules. They had blocked it at 40. We were at 40 for long, and now the code has been broken for us to use. So we use 34. Anterior energy from 70 is down to 30. And the ring energy from 65 is down to 31. And entry energy from 65 is down to 33. What does it translate to? It translates to cleaner corneas the next day. It translates to more patients coming to 20/20 the next day. Less the energy you use, the better. So what is done in the lab, or what is done is an attempt, or it was a question, no dissection. I think that was something which was the focus, that it should be an easy dissection. But what you can see is that the dissection ease still remains significantly same, if not better. The next thing that I will wish to have is that I want a line or a spot separation to reduce the energy further. So I hope that will be the next phase that we will be talking about. And this is what is on the horizon. A single piece patient interface work is going on in US. Line and spot spacing is something that I am pushing them for. In the lab, we have done hyperopia and mixed astigmatism. And tomorrow, obviously, once these things are done, we can look at wavefront guided lenticule extraction, which could be the next gen in the refractive correction. So this has been our journey so far in the development of ELITA. And with this, I think I would personally wish to say that it has been an exciting journey. Whenever somebody is associated with the development of a new technology, it really is thrilling, and has been a wonderful journey in us getting to these results. And there are so many people here, so there has been a lot of units. I think in India you have done about 25,000 eyes, right? So that's a good number since it was commercially available, and we hope that the numbers will grow. Thank you very much.